On-the-scene video coverage of AHA 2012 is supported by Pradaxa.
Yeah, thank you very much. The Freedom Trial was a trial sponsored by the National Heart, Lung and Blood Institute.
Big green arrow.
Yeah, thank you.
The big green arrow.
The trial design is eligibility. Patients with diabetes and multivessel coronary artery disease were randomized into multivessel stenting with drug-eluting stents and CABG with or without cardiopulmonary bypass. This was a randomization 1-to-1, and the patients were very significantly and aggressively treated with medical therapy, both groups. In terms of the trial design, this is a superiority trial of 7 years with a minimum of 2 years and a medium of 3.8 years. 1,900 patients divided equally in both groups with 131 centers across the world. The primary outcome, composite of earlier occurring of all-cause mortality, non-fatal myocardial infarction, and non-fatal stroke. And secondary outcomes of significance are the MACE of 1 year, death, MI, stroke, and repeat revascularization, and cost effectiveness, which will be presented later. There are 24 people who were part of the committee, experts on trials, experts on intervention, surgical or non-surgical, experts on diabetes and stroke. Here you have the definition of diabetes following the American Diabetes Association. Angiographically, these were patients with multivessel coronary disease with severe lesions of at least 2 measured epicardial vessels. Indications for revascularization were actually ischemia or myocardial ischemia or angina. Here you have the inclusion criteria, exclusion criteria. I don't think we have to go into too much detail. And here we have the definition of diabetes in terms of hemoglobin A1C, less than 7%, target LDL, less than 70 milligrams DL, target blood pressure less than 130/80. Pre-randomization, all qualifying angiograms had to be reviewed by the interventionalist and the cardiac surgeon. Here you have some details in terms of CABG management. These patients who had left anterior descending coronary artery. We encourage internal mammary artery revascularization. And then the question is conventional bypass versus off-pump CABG. This was decided by the surgeon. In terms of the interventional pre-stent process, all the lesions were looked at very carefully by the interventionalist. And I just want to point out that left main disease was actually excluded. Here we have another aspect, perhaps of interest, that drug-eluting stents were used in all patients, and actually in each particular patient who had intervention with the stents, the same drug-eluting stent was used. We have some interventional issues in terms of therapy. Oral aspirin, of course, was given, and clopidogrel, anticoagulants. Clopidogrel was discontinued at about 1 year in most of the cases. The definition of myocardial infarction, I don't have to go into the details. We divided myocardial infarction within the first 30 days and after the first 30 days. The stroke definition, neurological deficit of central origin lasting for more than 72 hours. In terms of the number of patients that enter into the trial, I think it's important to notice that over 100,000 patients were actually looked at, and from these, 10% were randomizable, and from these 10%, 60% enter into the trial, 1,900 patients. Again, in terms of the characteristics, were exactly the same clinically, hemodynamically, and laboratory testing for both groups, and so the medications given in both groups. Now, we are going to touch into perhaps the most important aspect of my presentation today, which is the primary outcome. In red, you have PCI drug-eluting stents. In yellow, you have CABG. In the horizontal axis, you have 5 years of follow-up. In the vertical axis, over 30%. As you can see, there was a significant difference between CABG and PCI. The event rates at 5 years in PCI, was 26.6%, and in CABG was 18.7%. Very, very significant. Here we have the myocardial infarction, which was also significant in favor of CABG. PCI drug-eluting stents, the rate of infarction at 5 years was 13.9, and in the group with CABG was 6%. Very significant. And here is all-cause mortality, which in fact at 5 years we have 16.3% in the PCI group and 10.9% in the CABG group. In terms of a stroke, this was a slightly increase in the group undergoing bypass with 5.2% at 5 years, and in the PCI, 2.4%. And here you have, in terms of repeat revascularization at 12 months, 13% with PCI, 5% with CABG. Actually, we have the data at 5 years, and it's 30% versus 13%. And here you have the MACE, which is the combination of death, stroke, myocardial infarction, and repeat revascularization, which at 12 months is 17% for PCI, 12% for CABG. Again, statistically significant. This is a very important issue, and this is the complexity of disease. This is the syntax score. In the upper right, left, a score of less than 22, we have the rate of events for the group treated with PCI, 23%, for the group treated with CABG, 17%. Also significant is the syntax score 2332 on the right upper side, 27% event rate for the primary endpoint in PCI, 17% in CABG. In a syntax score of more than 33, also significant difference of 30% for PCI, 22% event rate at 5 years for the CABG group. This slide is important because what it shows is that PCI does worse than CABG in all the prospective subgroups that were analyzed. And with each group, all the variables had the same favorable result with CABG. On the top, for example, is the syntax with the 3 groups that I presented, and all the other groups are below. Let me conclude, and that is that in patients with diabetes and multivessel coronary artery disease, CABG was of significant benefit as compared to PCI. MI and all-cause mortality were independently decreased, while a stroke was slightly increased. There was no significant interaction between the treatment effect of CABG on the primary endpoint according to syntax score or any other pre-specified subgroup. CABG surgery is the preferred method of revascularization for patients with diabetes and multivessel disease. Thank you very much.